All right, so now we're gonna do perfusion 2, which is chapters 29 and 30. So we're gonna work on SLO 2 and 3. So we're able to examine the action, uses, side effects, and nursing considerations for drugs to treat shock, anaphylaxis, and hypertensive crisis. Formulate nursing care for drugs to treat dysrhythmias. Okay, so 29 and 30. We're gonna do chapter 30 first. Okay, so dysrhythmias. All right. So this is abnormal electrical conduction in the heart. This is also known as arrhythmia. It could be harmless or life-threatening. Okay, so we classify them by their type of rhythm abnormality and where it's at. Supraventricular is the atria. Supra means on top of. So on top of the ventricle is the atria. So these are atrial dysrhythmias. Ventricular dysrhythmias are ventricular dysrhythmias. They are more serious. Okay, the atrial rhythms are common, ventricular rhythms serious. Okay, these are the different types. There are more than this. Okay, this is just in case you see these are dysrhythmias. Okay. All right. So now we're going to get into like how the heart beats, and it's going to get really convoluted. If you can't understand it, that is a-okay. But level 4, you're definitely going to need to know this stuff. Okay. So understand it the best you can. It takes time. Okay. This is not easy material. All right. So dysrhythmias, a defect in conduction of the impulses. So the action potential is the signal that makes the cardiac cells contract, and it's the beat. The SA node, as we remember, is the pacemaker. It controls automaticity, and it controls sinus rhythm, which is what we want. That's a good rhythm. Sinus rhythm, normal sinus rhythm is good. That is what we want. Okay. So if this is just an A&P review, we have our SA to our AV, bundle of His, and the right and left bundle branches, the Purkinje fibers. That is how it works. Okay, just keep that in the back of your mind. Okay. All right. So an ECG, EKG, electrocardiogram. So this is how we see what's going on with the AV, with the nodes. Okay. So we see the electrical impulses. This is how we diagnose arrhythmias, dysrhythmias, lethal heart dysrhythmias. Okay. So when anything changes within the EKG, that's how we know. Okay, so this is my beautiful picture from TikTok. Okay, I found it on TikTok. It's the best thing. It's the best video. If I could link the video, I would, but TikTok doesn't work here. It's the best video that has explained it to this day. Okay, it is still hard for me to understand it fully. Okay, so this is what an EKG looks like on the bottom. The P, QRS, T. Good news is there's not going to be any EKGs on your test, okay? But this is what we're talking about. So when the P happens, that's when the SA node hits the AV node and says, hey, you need to do something, okay? Because your SA node is telling your heart to beat, right? So the SA hits the AV, and the AV says, huh? What did you say? And that's that little break right here called the PR interval. And so that's the normal AV node delay. So your AV node's like, what? I got to do what? Oh yeah, I got to tell the rest of the heart to beat. So that's that break, and then it tells everything else to happen. And that is what happens. This is all the other, from the AV node down, this is what happens. That's the QRS. The T is the relaxation or repolarization. Okay. We're going to talk more about that in a minute. If you can remember that relaxation means repolarization, it's going to make it a lot simple. Okay. So that is how the heart beats. That is what it looks like. And when we read an EKG, that's what it reads. And there's lots of things that go wrong. Okay. So when we're talking about a dysrhythmia or an atrial dysrhythmia, and that's going to be here. It's going to be in the P to the QRS. When we have a ventricular dysrhythmia, it's going to be behind it. Okay. So if we have something funky happening in any part of this, whether it's not happening, whether it's not the right kind of beat, it's not this pretty dun dun dun. Okay, if it's not that, that's a dysrhythmia. Okay. All right. So when we talk about action potentials, which is going to be why we've talked about this, is because that's how the pharmacology works, and it makes sense. Hopefully. Okay. So Sodium, we have our sodium ion channels, okay? So when this, remember way back in A&P when we're talking about, muscles, the sodium, potassium, channels. So the sodium ions are like, hey, let me in. I need to come inside. You need to send the potassium out and let me in. So that is what we call depolarization, which is when the ions go in. Okay. So when the sodium and the calcium go in, that is depolarization. All right. So when the calcium ion channels open, calcium enters, and that says, hey, you got to beat. I'm gonna make you beat, because that's what calcium does. The sodium does the impulse. The calcium says, hey, you got to beat. So this is when the SH, the AV cells depolarize, so go in. And in response, the calcium influx happens, and it says, hey, I got to beat. So I got to do something about this. This is the AV saying, bring it in, let's beat. All right. So now we enter repolarization, which is when everything goes back to baseline. Okay. So this is when all the ions go back outside the cells. So the sodium and the calcium go out and the potassium comes in. Okay. So how do we treat dysrhythmias? We block one of those things, the sodium, potassium, or the calcium. Or we block the SA node. We block the AV node. Okay. So either it works on the ions or it works on the nodes. All right. So cardioversion, and these are non-pharmacological therapies for dysrhythmias. Cardioversion, defibrillation. Okay, cardioversion and defibrillation are not the same thing. They are different. Cardioversion is when you obviously use them for serious arrhythmias. This is when you shock people. We don't shock people just for the fun of it, okay? And they have to have a shockable rhythm. You can't just shock anything, okay? And cardioversion, you have to have a P wave, because we have to sync on the P wave to be able to shock you, because that's what your SA node, that's when your SA node's talking to your AV node. So we have to sync on that part of your EKG, and they shock you right then, so that it says, beat the right way, please, okay? That is cardioversion. Defibrillation is when you don't have a P wave, okay? And you have a shockable rhythm, because we don't shock asystole, okay? We only shock certain rhythms. So when I don't have a P wave and there's nothing to sync to, and I just need to shock them to say, hey, SA node, wake the heck up and start working, that is defibrillation. Cardioversion is when I need to make the SA node act right. Defibrillation is when I need to make the SA node wake the heck up. Okay. All right. So then we have catheter ablations or cardiac ablations. This is when they go in and they like burn the cells that cause the dysrhythmias of the heart. Okay, it's used a lot for atrial AFib, aflutter. You can get a pacemaker or a defibrillator or a combo. Okay, they're not the same thing. A pacemaker and a defibrillator are not the same thing. A pacemaker keeps pace. Okay, so it's making your heart beat. It's on the SA node and it's saying, work, 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 work. The defibrillator works like the defibrillation. It shocks when it reads your heart rhythm at all times. And when it goes into one of those shockable rhythms, it shocks you. Okay, you get a combo, that's cool. But if you have just a pacemaker, your heart will always beat. If you have a defibrillator, it's not working all the time. It only works when you need it to. And you better hope it's working then, okay? All right. So we have antidysrhythmic classes. We have class 1, 2, 3, and 4. Class 1 is our sodium channel blockers. Class 2 is our beta adrenergic block antagonists. We're going to get more into what, so we know what beta adrenergic antagonists are, so our beta blockers. Okay. We'll get to what they do. Class 3 is our potassium channel blockers. Class 4 is our calcium channel blockers. Okay. So these block some kind of ion or your sympathetic nervous system. Okay. Then we have miscellaneous. Those work on the AV and the SA nodes. Okay. So there's 3 types in class 1, ABC. They have similar structure and action to local anesthetics. One of them is literally lidocaine, which like numbs your mouth. Okay. We give it to you IV and it works with your heart. Okay. They do have the potential to create new or worsening dysrhythmias. Okay, and we have to take special care with adults, older adults. Sorry. So procainamide is a class 1 drug. We can give it PO, IV, IM. If it's a cardiac dysrhythmia and it's new and it's happening right now, we're giving it to you IV. Okay. We're assuming this is an emergency. This is IV. Okay. So this is a sodium channel blocker. It works for atrial ventricular dysrhythmias. It blocks the sodium ion channels and it reduces the automaticity and slows the conduction of the action potential. Okay, so what that means is it reduces the automaticity. So it tells that SA node to slow the heck down. And it tells them to stop making it beat so dang fast, please. So slows the conduction of action potential. So that QRS, that's the action potential, says slow the heck down. Okay, that's what this does. All right, common side effects, nausea and vomiting, abdominal pain, hypotension. That's a big one, right? We don't want them to have a crappy heart and be hypotensive. Okay. Headache in high doses, it can cause confusion and psychosis. To me, that's like red flag. That's a red flag. Because if my patient that I'm titrating this drug to make their heart rate, heart beat correctly, if I'm titrating it and it's working, sometimes it's working and we have to keep going up, and then they start going like look crazy and they start pulling stuff out and they start wanting to get up and go psychotic, I need to know that. Okay, I need to know that. And that's a side effect. Okay, so I can say, oh, we got to load this down. I have to call the doctor. We got to get something else, have it ready. Okay. All right. The other thing is that it can create new or worsening dysrhythmias. Another big side effect I need to know. And if that happens, we got to stop. Just stop the procainamide. You can reverse it with whatever they tell you to, but just stop it. Stop doing it. Okay. I feel like this goes without saying, but I'm going to say it anyway. If your patient is having a dysrhythmia and you're treating a dysrhythmia, they better be on a continuous cardiac monitor. Okay. All right. I feel like that's, self-explanatory, but I guess it's not. And I just want to make sure that everyone understands. I better be able to see their EKG the entire time I'm giving them any of these medications. Okay. Because if they start having this, how am I going to know they're having this new dysrhythmia? Am I doing an EKG every 5 minutes? No, they're on a monitor and it's continuously recording it. Okay. It's so important. I've seen people give drugs and then not on a monitor, and you're like, excuse me, what are you doing? If you can't see it, how do you know it's working? How do you know it's not making it worse? Okay. You got to be able to watch. All right. It can also cause agranulocytosis, bone marrow depression, neutropenia, hypoplastic anemia, thrombocytopenia. Okay. So we definitely got to monitor for bleeding. All right. So it also can do prolonged administration can increase the titer to anti-nuclear antibodies and cause a lupus-like syndrome. So it can like trigger your autoimmune disorders. Okay, which is also a big deal. So other antidysrhythmics, anticholinergics we want to avoid. Overdose is supportive. So if they're hypotensive, we give them fluids or vasopressors. If they're having a new dysrhythmia, we change to the right kind of class of dysrhythmics, or we use vasopressors as well. So if you have a complete AV block, which is atrial ventricular, we don't do it. You don't get this one. Okay. If you have severe heart failure, if you have blood dyscrasis, which is the anemia, thrombocytopenia, that stuff. Okay, so it's going to make it worse. And then myasthenia gravis, because it's also like an autoimmune disorder and we don't want to trigger it. Patients should be in supine, not Fowler's, because we want to reduce the risk of hypotension. So this hypotension is a pretty big deal. All right. Monitor their EKG very closely. All right. Monitor electrolytes, potassium specifically, because if we're messing with sodium, we're messing with potassium. Monitor blood pressure, monitor their CBCs, signs and symptoms of infection, bleeding, psychosis. All right. So then we have propranolol. This is a class 2. This is our beta adrenergic antagonists. We know we've talked about beta blockers for 3 semesters, and if you don't know them by now, we've got a problem. I'm not going to go over what they're for. Okay, they reduce your heart rate. They slow the myocardial conduction velocity, so they tell your heart to slow the heck down, and they lower your blood pressure, as we know. Okay, so side effects: fatigue, hypotension, bradycardia. Okay, if you have also can have diminished libido and impotence. That's not my primary concern right now. My primary concern is your lethal dysrhythmia. Okay, but I will let them know later. Okay, hypoglycemia. You can have if you have chronic kidney disease, you can have an increased risk of toxicity and dysrhythmias. That is a big deal. All right, I'm not going over what meds to avoid because you should know that by now. Treatment overdose, reversing hypotension with vasopressors, reversing that bradycardia with atropine. IV glucagon for to reverse cardiac depression. All right, if you're in cardiogenic shock, you don't get beta blockers. If you're already sinus brady, you don't get beta blockers. If you have greater than a 1st-degree heart block, which means which is a type of dysrhythmia, and usually it means your heart's not beating very fast. So once again, you're not getting a beta blocker. If you have heart failure, COPD, or asthma as well, because of the possible beta 2. So administration alerts. Stop it if stopping abruptly can cause a heart attack, severe hypertension, or ventricular dysrhythmia. So we don't stop abruptly. We wean. Okay. Do not crush the enteric, the extended release tablets, and the heart rate's less than 60. Ain't happening. Monitor their EKG. Monitor their respiratory status. Monitor their blood pressure. Monitor their heart rate. Monitor their blood sugar. Tell them not to stop it abruptly. Avoid smoking, alcohol, and illicit drugs. All right. So calcium channel blockers. Once again, we should know what this is too because we talked about them. But we're going to talk about one that you probably haven't heard of before. So these help with dysrhythmias by repolarization, which is the relaxation, depends on the potassium's gone back inside the cell. So if we delay the relaxation, we'll block potassium channels. And so that's how the calcium channels work. So we use amio. Amiodarone or Pacerone. Amiodarone we use a lot. It's a very common drug to use if people come in with one of these arrhythmias. Okay, it's used a lot. Get comfortable with it. I'm so sorry. Potassium channel blockers. If I said calcium at some point, I'm sorry. Potassium channel blockers. So this is a potassium channel blocker. So it blocks the potassium from going back inside the cell. So it delays the repolarization. And so we use it for ventricular tachycardia and atrial dysrhythmias. It has a lot of very serious side effects: pulmonary toxicity, elevated liver enzymes, thyroid toxicity, a blue-gray skin color, blurred vision, rash, photosensitivity, nausea, vomiting, anorexia, fatigue, dizziness, hypotension, pneumonia-like syndrome. So that can go along with the pulmonary toxicity. This is a black box warning. Bradycardia, because we're delaying repolarization. Cardiogenic shock. AV block, which is not a good block to have. Mild liver injury. Those are very serious, and that's a lot of black box warnings. So we have to know them. Okay. Avoid warfarin, beta adrenergic antagonists, calcium channel blockers, and other meds that prolong the QTC interval, which is the QRS. If it makes it longer, we can flatten. Okay. So if anything that lengthens it, we want to avoid. St. John's wort and grapefruit juice we avoid. Treatment overdose, reverse the hypotension with vasopressors, reverse bradycardia with atropine. Contraindications: severe bradycardia, cardiogenic shock, because those are the black box warning. Sick sinus syndrome, which is a type of arrhythmia, severe sinus node dysfunction, and 3rd-degree AV block. So once again, continuous monitoring must be available. Okay, resuscitation equipment have to be there. So amiodarone is one of the drugs I keep in a code cart, and they just have a vial, and they have bags of saline. and you've got to figure out which one to mix it with to hang we call them dirty bags because the nurses made them and they don't like that. Okay, so if you need to hang a bag of amiodarone and you've got to make the infusion yourself, you got to know which one to grab. And you need to grab D5W because that's the only thing it can be mixed with. No saline. No normal saline, no half, no LR. D5W. Okay. All right. A 10-gram loading dose is needed. So you need to give 10-gram bolus and then we'll start the infusion. Okay. The IV infusion is usually limited to 2 to 4 days. The therapeutic, they do check ranges. Therapeutic range is 0.8 to 2.8. Monitor their respiratory function and prior to and during treatment. Monitor their liver function, monitor their blood pressure, their heart rate, their EKG. If they take this PO, if you take it with food, it can help with the GI, the nausea, vomiting. You need to monitor for their thyroid, monitor their skin, monitor their vision. Okay, those are things that are not listed that need any of these side effects we've got to look out for. Okay. All right. So now we're into calcium channel blockers. We know about those as well. Okay. So they reduce the automaticity of the SA node and slow the impulse conduction through the AV node, similar to the beta blockers. Okay. Verapamil is the one we're going to talk about. So this is a calcium channel blocker, inhibits the flow of calcium ions. Remember, calcium makes your heart contract. So it slows the conduction velocity, stabilizes dysrhythmias. Okay. So we use it for angina, PSVT, to prevent PSVT, SVT, hypertension, vasospasms, AFib. Okay. Not many adverse effects: headache, flushed skin, constipation, hypotension. Nowhere on here does it say it affects your heart rate. Okay. It doesn't cause Brady or tachycardia, but it will affect your blood pressure. Okay. Drugs we want to avoid: digoxin, beta blockers, and antihypertensives, because we don't want to make you more hypertensive, right? Grapefruit juice and caffeine we should avoid. Reverse hypotension with dopamine or Norepi, which we're going to talk about soon. And calcium salts to increase the calcium available. Contraindications: AV heart blocks. Again, sick sinus syndrome, severe hypotension, you have a bleeding aneurysm, intracranial surgery, CKD, and hepatic impairment. Don't crush the ER tablets or capsules. Monitor their EKG, monitor their blood pressure. The reason it says heart rate is because we want to monitor their arrhythmia. Okay. Avoid alcohol. All right. All right. Now we have our miscellaneous ones: adenosine and DIG. Adenosine is very popular. We use it a lot. Okay. So the mechanism of action is to decrease the automaticity of the SA node and slows the conduction through the AV node, but does not act on blocking ion channels. All right. If you've ever had computer troubles and you call IT and they say, have you tried turning it off and turning it back on again? That's adenosine. It will stop your heart and restart it. Okay. That's what it does. It's what it's supposed to do. It may not be a long one, but a long pause, but it will cause a pause up to like 15 seconds. That is the longest 15 seconds of your life. Okay. Serious, we use it for SVT, which is supraventricular tachycardia or atrial tachycardia. Okay. So if my patient is about to not have a heartbeat or a pause, I don't care how long the pause is supposed to happen. If they're about to have a pause, what do I need to have? They better be on that continuous cardiac monitor, right? They better be hooked up to a defibrillator as well. Okay. I better have CPR equipment available, because if that pause turns into dead, which it can, I need to be ready. Okay. So the adenosine says, SA node, stop what you're doing and then restart. If it doesn't restart, they don't have a heartbeat. Okay. So they better be on that defibrillator. They better be on that cardiac monitor. All right. Because it's the longest 5 seconds of your life, watching the heart just stop and then start back up. Okay. A lot of times they'll like have a syncopal episode. Sometimes they'll have facial flushing. They have shortness of breath. That's common. Okay. Digoxin, we know how digoxin works from Pharm 2. They use that for other atrial dysrhythmias. The adverse effects for both is that they can create new dysrhythmias or worsen existing ones. We just talked about that. The new dysrhythmia being asystole or VFib. So we need to have, that's why it's important to have that stuff ready to go. We got to prepare for the worst case scenario. We know digoxin side effects: nausea, vomiting, headache, visual disturbances. All right, so now we're done with the heart, kinda. We're gonna talk about shock. So shock, there's different types of shock. They're listed on the bottom. So this is overall, the problem is that we don't have blood flow to meet our body's needs, whether it's being stopped, whether we don't have any blood, whatever's going on. Okay. These are medical emergencies. They can cause organ damage and death. They're classified by their underlying pathological condition. And whatever is causing the problem, that's how we diagnose it. So if it's my heart, it's cardiogenic. If it's my brain, neurogenic. All right. So hypovolemic is a loss of blood volume. And now this is not just like, oh, I'm dehydrated. Oh no. This is severe dehydration. This is I'm lost all my blood. I've been stabbed multiple times and I have no blood left. Okay. Neurogenic shock from vasodilation due to changes in the autonomic nervous system, like a spinal injury, okay, or a brain injury, and now my brain says, crap, I don't know what to do anymore. And so it causes a vasodilation. Cardiogenic shock, failure of the heart to pump blood sufficiently. Cardiogenic shock is not easy to treat or diagnose. Sometimes it's from like just cardiac trauma. Sometimes it's not. Okay. Anaphylactic shock, we know what that is. It's you have a reaction to something, an allergic reaction to something. Okay. Septic shock is multi-organ dysfunction. There's a lot about septic shock because it's like the most common shock you see. It's usually from a pathogenic organism. So I have some kind of infection, whether it started out in my urine, in my lungs, in my mouth. Now it's moved to my bloodstream, and my blood is so infected, it's junking up everything. And so my blood cannot pump properly. It's affecting my entire body. Okay. So initial priorities, ABC, airway, breathing, circulation. Isn't it BAC now? Breathing, airway, breathing. Yeah, no, airway, breathing, circulation. Okay. Identifying underlying cause, obviously. If we don't know what's causing it, how do we treat it? They need to be on a cardiac monitor and apply a pulse ox. That goes along with cardiac monitor. Cardiac monitor means EKG, blood pressure cuff, pulse ox. Everything better be hooked up. And we better have it on a cycle to go often. Oxygen, especially if it's anaphylactic, okay? They need to be on oxygen. Monitor their level of consciousness to make sure that they're not, dying or going into a coma. Keep them warm and quiet unless they have a fever with septic shock, okay? But we want to be sure, especially with hypovolemic, they need to be warm because they don't have any blood, okay? And then if they need other kind psychological support, that's okay too. All right, so hypovolemic shock, we have IV fluids. If it's blood that we've lost, it's blood I get, okay? Whether it's whole red blood cells, like packed red blood cells is what they call it. That's got all the blood products in it. It's got blood, plasma, and platelets, all of it. Whole blood cell, whole blood. So if you don't know what I need, you just give it all. If you know I just need a clot, you give me platelets. If you know I need plasma, you replace the plasma, okay? You can give me all of it. We do emergent transfusions. There's another name for it, but I can't think of it. And you get like 3 or 4 red blood cells, a bunch of platelets, and then plasma. And it's like, it's a bunch of blood products in a box, and you give it all really, really fast, okay? So we reserve that for severe cases, but whatever they need, we'll give it to them, okay? So you can also give IV fluids, so colloids and crystalloids. Colloids, you can give blood product colloids is what they call them. So your albumin, your plasma protein, your immunoglobulins. or you can give non-blood colloids, which is your dextran and your hetastarch. Crystalloids, those readily leave the blood and enter the cell. Okay, so this is when we have like we don't need volume. Our volume in our blood's important, right? But our tissues are so dehydrated, we need to get the tissues rehydrated as well. So these contain electrolytes, and they can like even resemble plasma. All right, albumin. So they use this for fluid replacement drug. We used it a lot when when I worked in IR, when someone had a paracentesis and they took out a lot of fluid, and the albumin would kind of help it from shifting right back. So it's a normal like protein kind of in your body, and so it kind of keeps all the blood volume in the blood vessel. Okay, so we use it for hypovolemic shock, hypoproteinemia with hepatic cirrhosis, which is why people got paracentesis. So it increases the osmotic pressure of the blood and causes fluid to move from the tissues to the general circulation. So it keeps it all in, okay, which is what we want if we're in shock and we don't have any blood. So you can have an allergic reaction to the donor's antibodies. So fever, rash, chills, shortness of breath. You can have circulatory overload. So now you've kept too much blood in your blood volume and your heart can't keep up, and you can have edema. There's no drugs, foods, or treatment overdose. Severe anemia, cardiac failure, and an allergy obviously are contraindications. Infuse at high concentrations. Infuse high concentrations slowly to prevent a rapid fluid shift. When they mean that rapid pull from the tissues. It needs to go through a pretty large IV, 16 to a 20 gauge IV. Monitor their infusion, monitor their blood pressure, monitor for fluid overload, like shortness of breath, crackles, things like that. Monitor for allergic reactions. All right, so then we have vasoconstrictors or vasopressors and inotropic drugs. Vasoconstrictors vasoconstrict. Okay, so instead of a vasodilate, like with our vasodilators, these ones do the opposite. So we use this when we need our blood pressure to go up because we're not perfusing our brain, and my brain needs blood. Okay, because it's got to work and tell the rest of my body to work. So it clamps down on all the blood vessels and keeps them really tight so that all my blood pressure goes up, and it seems like it's adequate. It's an adequate blood volume, okay? Or it's just keeping my blood pressure up. All vasoconstrictors cause peripheral ischemia. We'll get into that when we talk about one, but all of them cause peripheral ischemia. Okay. Inotropic drugs. They're also called cardiotonic drugs. So this is the reversal of cardiac symptoms of shock. Okay, we know about inotropes from Pharm 2 when we talked about positive inotropic drugs. Okay. So Norepi or Levophed, super common. We give it a lot. It's like one of the first lines for severe hypotension. Okay. Acute shock, cardiac arrest. It's a sympathomimetic that acts directly on the alpha adrenergic receptors and vascular muscles, smooth muscles, to immediately raise the blood pressure. It has immediate onset. You can give this IV push. I don't recommend it, but you can. They do that for like emergent type situations, but an infusion is usually what we do. So you can have reflex bradycardia, which means it's not supposed, like reflex bradycardia means that it's really not supposed to cause bradycardia, but it can like paradoxically cause it. It can cause a dysrhythmia, blurred vision, photophobia, which is a sign of overdose. The black box warning is an extravasation. If it extravasates, it can cause really bad tissue injuries and skin sloughing. So you need to inject the area with phentolamine. Okay. We want to avoid alpha and beta blockers, ergo alkaloids, tricyclic antidepressants, and MAOIs. Okay. No foods. Treatment overdose is discontinuing of the IV. And we're going to put an asterisk, and we're going to talk about that in a minute. Okay. So there's an asterisk next to that. Please don't forget that. All right. Hypotension due to blood volume deficit is a contraindication. So if I don't have any blood volume, I don't really need vasoconstrictors. I need plasma expanders, volume expanders, okay? There's only so much vasoconstriction we can do. If you don't have enough blood, you don't have enough blood. If you have mesenteric or peripheral vascular thrombosis, because of the peripheral ischemia or decreased urine output. Okay. So you have to ensure IV patency before you do it. Obviously monitor their rate and flow of the medication. They better be on that cardiac monitor. They better be having that blood pressure being going every 5 minutes, if not often. Do not stop it abruptly. Okay. Now it says treatment overdose, stop the infusion. It does not mean, oh, they're having bradycardia. Oh, they're having a decreased urine output. Oh, their fingers are turning blue. We need to stop it. That doesn't mean just turn it off. It means gradually wean them and then turn it off. Okay. All right. A central a central venous catheter is preferred because of the soft tissue injuries with estrabization. Okay. Monitor their EKG, monitor their blood pressure, heart rate, cardiac output, urine output, color and temperatures of limbs for peripheral ischemia. So, vasoconstrictors. As we well know, your heart flows through arteries, it goes all the way down and supplying oxygen, and then it crosses over those capillaries and comes back to the venous circulation, right? So it's not selective, and it constricts all of it, okay? So those capillaries that are so small, and the arteries and the veins get smaller, the smaller they get here to the distal ends, we constrict those. And sometimes we constrict them so much, we cut off blood flow. Okay, so that is what they mean by peripheral ischemia. So that's why you can't use it if you already have a mesenteric or peripheral vascular thrombosis. If you have a DVT, which is a deep vein thrombosis, if you have an arterial thrombosis, they don't want you to use this because we're already going to vasoconstrict and cut off the blood flow to the distal parts. We don't need to make it worse, okay? So I know a patient who had DKA, which is diabetic ketoacidosis. She couldn't get her sugar under control, and it was so bad she had severe hypotension, and she was on Levophed for a long time, way too long. She has no arms or legs anymore. They're cut off above the elbow and above the knees, okay? All from this medication, okay? I'm not joking. It will cause your fingers to fall off, your legs to fall off, because it vasoconstricts that much. It shunts the blood to the trunk, because these are vital organs, to your brain, because that's where we care about. You can live without hands. You can't live without your vital organs, okay? So the titratable drug is a titratable drug, and it must have parameters. And what it means is I need to have a MAP within over 65. I need to have a systolic blood pressure over this, and that's what we titrate it to. There's like increase, decrease by 5, by 3, whatever. Okay. It also needs to be protected from light. Okay. All right. Dopamine. Dopamine is one of the inotropic drugs. So we use it for shock. It's a low doses selectively stimulates dopaminergic receptors, vasodilation, and increased blood flow. High doses stimulate the beta-1 adrenergic receptors, cause the heart to beat more forcefully, increase cardiac output, and stimulate alpha adrenergic receptors, causing vasoconstriction and raise the blood pressure. Okay, so we're using the higher doses for these for the shocks. Okay, monitor for a dysrhythmia. All right, high blood pressure, because it can work too good, right? Vesicants, it is a vesicant, severe irreversible skin and soft tissue damage. You need to have that phentolamine ready, all right? That is also what they use for the treatment overdose. So the drugs you want to avoid: MAOIs, phenytoin, beta blockers, alpha adrenergic blockers, certain antidepressants, antipsychotics. No foods we have to worry about. If we have an overdose, stop the IV, give the phentolamine to stabilize the patient. We don't use it for phenochromatomas, which are small tumors, I believe, on your adrenal glands, and BFib. They don't get dopamine. So ensure the IV patency because we do not want it to extravasate. Monitor their infusion rate and flow. Monitor their EKG, blood pressure. Almost the same exact nursing interventions. Central lines preferred. Monitor for extravasation. Monitor EKG, blood pressure, cardiac output, urine output, peripheral ischemia. These are your low and your high doses. Do not stop it abruptly. Once again, we have to wean it. So when we say the urine output, we didn't talk about this with the Norepi, but the same principle applies. The reason why we monitor for the urine output is because of the peripheral ischemia. I mean, because of the peripheral ischemia and for the vasoconstriction. So when we start having decreased urine output, it means that we are constricting everything too much, okay? So the blood can't get back to the bladder to filter and pee. Big deal. We definitely need to monitor urine output for both of these drugs. We also need to monitor for chest pain because they start having the dysrhythmias or high blood pressure, that can cause chest pain. The other thing is the whole point of these Norepi and dopamine is we're trying to raise their blood pressure. Okay, so once the blood pressure becomes normal, we can start taking it down. Okay, we got to go all the way up until it gets normal and it's above a 65 or above 65 MAP. But once it gets above whatever the recommended is, we can start seeing if we can come down because we don't want to, we don't want to have that peripheral ischemia for a really long time. Okay, so once we have a good blood pressure, we can come back down. All right, anaphylaxis. Fatal hypersensitivity to an allergen. Signs and symptoms: itching, hives, periorbital edema, swelling around the eyes. Then it can lead to tightness in your throat, chest, wheezing, hoarse cough, rapid fall in blood pressure, so severe hypotension, difficulty breathing. Treatment: an EpiPen. Okay, we want to support the cardiovascular system. We want to prevent hyperreaction to immune system. So we give them oxygen. We give them antihistamines because we need to stop the histamine release. And you give them bronchodilators to help with the swelling in the throat, and then corticosteroids to help with the swelling. They like the go-to thing to give when someone comes with angioedema or with an anaphylactic shock is Pepsid, which is an antihistamine, methylprednisone, Benadryl, Epi, and albuterol. Okay, the bronchodilator, nebulizer. Okay, those are like the go-to drugs for it. When you have an EpiPen, which we're going to talk about in a minute, your patient needs to know how to use it on themselves. It's a big deal. If they don't know how to use it, that's a problem. You need to teach people around them how to use it. Anyone that's going to be with them a lot. They probably need to carry 2 of them, okay? Because sometimes the needle misfires. Sometimes they don't use it correctly. If that happens and you only have 1, you're screwed. I'm sorry, that's not appropriate, but you gotta, so carry 2, okay? I had a little girl come in, and her sister gave her the EpiPen shot. It didn't work because she poked herself. She had it upside down, and when she went to stab, she stabbed her own thumb. Good thing she had 2, because then she turned it around and gave her the real one, okay? Because it's a 1-dose thing. The EpiPens are 1 doses, that's it. All right, EpiPen. Epinephrine, you can give it IM, IV, sub-Q, topical, inhalation, ophthalmic. We're talking about IV, IM, okay? So as a non-selective adrenergic agonist and a vasoconstrictor, we use it for shock, anaphylaxis. This is not just for anaphylaxis. They use epinephrine drips for shock, for your heart, cardiac stimulation, cardiogenic shock. So midrasis during intraocular surgery, they also use it for them. So like we said, it's non-selective adrenergic agonist, blood pressure rises, bronchi open, cardiac output increases. It's a pretty fast onset IM. Side effects. I don't know if everyone knows what like a shot of adrenaline, like it's just called adrenaline. They've all seen it on TV. You get like nervous, you get the shakes, palpitations, feel like your heart's running away, tachycardia, dizziness, headache. It can hurt at the injection site, high blood pressure because it's vasoconstricted too much, dysrhythmia. Drugs we want to avoid: MAOIs, alpha and beta adrenergics, beta blockers, anesthetics, antidepressants, antipsychotics. Okay. I know all these drugs say avoid. MAOIs, I think are real, but if you have an allergic reaction, they're probably just going to give you epi. They don't care. I'd much rather, we'll treat the adverse reaction later. What they mean is after you've had epi, let's not give you all these drugs, okay? Avoid caffeine. If your patient's on like an IV epinephrine drip, let them drink coffee, okay? Treatment overdose is alpha and beta adrenergic blockers, vasodilators for high blood pressure. Treatment, there are absolutely no contraindications during anaphylaxis, like I just said. The same doctor who told me we were talking about the heparin. No, it wasn't her. They look alike. Another new doctor told me one time, I had a patient come in with anaphylaxis. I mean, the throat swelling, face was swelling. I said, I'm going to get the epi. She said, I gotta check their allergies. I said, excuse me. No one's allergic to epinephrine. So people put that it's an allergy on their allergy list and they're like, oh, it makes my heart beat really fast. That's what it's supposed to do. I hate to tell you, but you're going to get it if you're having an anaphylactic reaction. Okay. There are no contraindications if you're having if you're at an anaphylactic shock. All right. Caution for dysrhythmias: cerebrovascular insufficiency, hyperthyroidism, narrow angle glaucoma, high blood pressure, CAD. So if they're going to need the IV solution for shock, cardiogenic shock, something like that, then that's when we worry about the contraindications. Okay. If we're giving it for the intraocular surgery, that's when we worry about the contraindications. Okay. If it's anaphylactic shock, I don't care, you're getting it. Okay. Unless you tell me no, then I won't do it. All right. If extravasation happens, it can cause soft tissue and skin injury. Monitor for rebound anaphylaxis. This happens a lot, especially in children. I had a little kid. The dad accidentally gave him something with peanuts and he was allergic. He didn't know it had peanuts in it. We gave him the epi. We gave him the whole everything. An hour or two later, he had another reaction. Okay, it's a rebound anaphylaxis. It wears off, and you need more. Okay, you have to monitor their EKG, their blood pressure, heart rate, vital signs, airway. Obviously, they're in anaphylactic shock. Okay, repeat the dose if needed. Tell the family and the patient how to use an EpiPen properly. Okay. And that is the end of Perfusion 2. I hope you've had fun. Please study. It's a lot and it's hard and I get it. If you have questions, put them in the discussion board, email me, whatever you need to do. Study hard and good luck.